I request Professor Ramesh Ardhanari, our senior beloved teacher and pioneer of minimal access GI surgeon. He will be speaking on intraoperative bleeding in low anterior resection and APR. Ramesh sir.
I've changed the topic a little bit because all rectal surgery is virtually the same planes of dissection now. So I made it intraoperative bleeding during rectal surgery. So it includes rectal prolapse and whatever other things you mobilize the rectum for. As you can see, I have only 5 slides, so it's a very short presentation. No clips because I haven't had a thing from which I could show a bleeding or something. So I'm going to discuss only very basic things. On the 5 slides, one is my name slide, so you are not going to okay. Now, where do we get troublesome bleeding? I am no longer talking of bleeding from the abdominal wall or access bleeding because I think those are common for all surgeries, so I'm not going to go and talk about that. I'm going straight away to rectal surgery. And the problem with rectal surgery is that as you mobilize, if you keep in the correct plane, which Bill Heald described, which he called the holy plane of rectal dissection. If you stay in that plane between the 2 layers of the Waldeyer fascia, the visceral and the parietal layer, the veins will remain behind the parietal layer. So they will not get injured. So it's very important that you must remember. Now, what happens when they get injured? See, you see that these vessels, they come, there is this one middle sacral plex vein and then some side veins, and they have communications through the sacral foramina with the intravertebral veins. So what happens is that they often get torn, partially or completely, and one part goes into the foramen and keeps bleeding from inside. It's easy to control the bleeder that's outside the foramen. All you have to do is ligate it, or you can take a good sealer and seal it. But the bleeding that keeps coming, oozing, that keeps collecting from inside the foramen, that is the bleeding that is difficult to control. And that is the bleeding that can cause major problems. As I said, because it lies between the 2 layers of the Waldeyer fascia, for the last 25 years, I think most rectal surgeons are now trained into going into that layer carefully. Now, when I was doing a postgraduate, and if you look at the old editions of Robin Smith of how to do rectal surgery, you will find this photograph of where the left hand is lifting the rectum and the right hand is dissecting the rectum from the posterior wall. Now, when you do that, you will tear it at wherever it is the weakest point. So sometimes that is where the tumor is infiltrating or something, and very often this hectic bleeding would continue. Second, in the olden days, we didn't have neoadjuvant therapy. So we operated all rectal cancers. There used to be huge rectal cancers, big tumors, and we'll operate them. And they will bleed like anything on the table because they're big, they've got a lot of vascular supply. And then, you didn't have good diathermies to really control the bleeding, and patients would often have a lot of complications and multiple blood transfusions. I distinctly remember when I was a senior registrar that one of the consultants was doing a rectal prolapse, and there was this bleeding, and he went on trying to do a biopsy, and I went on telling him, sir, pack karke, we will wait. He would not listen. He went on trying to do suturing and this and that. Then I decided, sir, aap jaake ek chai pee ke aa jaiye, tab tak dekh lenge. So when I sent him for the tea, I put one pack and put pressure on it. And we had one nice, hefty, young first-year resident. I told him, put your weight on it and sit. So after 20 minutes, he came back after his tea. He came back, then we put water on the pad and then gently shook it and removed it. No bleeding. So pressure is still the best hemostat. So in this situation, especially where the vessel is probably retracted inside, you pack carefully, pack some gauze pieces into the holes which you can see from where bleeding is coming. Put a pack and keep the pressure for 20 minutes. It has to be there for 20 minutes. So you can't be removing it every 1 minute to see if the bleeding has stopped. It won't stop. It will start bleeding again. So wait for 20 minutes, press it and wait. And it will usually stop bleeding. Now, sometimes it doesn't stop bleeding. Now, what do you do then? So, as is written in some of the books, presacral venous bleeding is rare but potentially lethal complication of rectal surgery for cancer. Incorrect mobilization. This is what we used to do because we used to just put our hand strip it off the posterior fascia, injures the presacral fascia and causes deinsertion of the fascia, leading to bleeding from the sacral venous plexus. This bleeding can be very difficult to control at the level of the last sacral vertebra due to the injury to the communicating vein. And this usually happens very low down, not properly seen. So the best place is to do pressure. But there are some other methods which have been described in literature, and I will tell you a little bit about some of them. Some of them we have not used, but we have read about it. Pelvic plugging means packing. This is just packing. This is you pack and wait for 20, but you have to wait for 20 minutes. And it usually controls 80 to 90% of the bleeding. This is not only true of the rectum, it is true of any part of the human body. So now what we have realized is that in the earlier part, we were doing, say, a major liver resection or doing some surgery, retroperitoneal tumor. A lot of oozing, we go on doing bipolar and cautery and this, it keeps oozing. But the oozing is actually worse than a vessel bleeding. A vessel bleeding, you can put a clamp, it stop. Oozing, you can't. And then the anesthetist will not tell you, you'll be quietly going on giving blood. The patient's temperature drops. He becomes acidotic. His platelets no longer function. He starts his DIC. And by this time, all your efforts will fail because DIC has set in. So we believe now that if you see this sort of oozing in the retroperitoneum or the liver post-operatively, after about 15-20 minutes, once you've given 1 or 2 units of blood, we do early packing and come. So previously, the results of packing were very bad. These patients will go on a ventilator, they'll go into ERDS, and then they will die. Now we pack them early, before they become cold, before they become ischemic. We pack them, they're not acidotic, shift them, keep them on a ventilator, and after 24 to 48 hours, depending on their stability, we bring them back into the theater. And the way to remove those packs is a very important way. What we do is that we open the abdomen and then pour almost half a bucket of water onto the pads. The pads must become soggy, so that when they are soggy, you just shake them loose from the tissues, so they don't tear the clots out as it comes. And you will see that 90% of the bleeding, 95% is controlled. Do a couple of bipolar or hemostasis, everything is cool, the patient recovers. So now with early packing, we find patients are recovering, which was not there when we did the delayed packing. At that time, they didn't recover. They would go for sepsis and die. There are metal implants which have been used. So the first thing that was described was a tacker. So the tacker has a round edge and a sharp point. And what they did was that into the hole from which it is bleeding, they put some gel foam or Surgicel and then put a tacker and pushed it in. And they would hold it in for some time. And sometimes the bleeding stopped, and that was described as a great advance in rectal surgery. I think it was the pressure that stopped the bleeding, not the tacker. I have never used this. I've seen it being described. I have not used. The other thing that you can do is you can use the metal implant and you can push in some. So from the abdominal wall, you take some rectus abdominis muscle and then you put that into that hole, tack it, and then you put a ball diathermy on top of the muscle, and give it a good blast. The muscle sort of melts, coagulates, and forms adherent coagulum, which stops further bleeding. This I found to be useful. I've only used it once in my life, so obviously we don't come across these cases of bleeding very often. But when I used it, it was successful. Some people have tried direct suturing of the vessels. As I said, it works on the external vessels, on the main sacral vein, on the internal iliac vein. These, if you suture, it will hold, but nothing will happen to the sacral plexus bleeding. That it doesn't hold. Then you do direct or indirect coagulation, like I told you, using a muscle or a direct. You into the hole, you put the round ball tip of the diathermy. So keep always a ball tip in your theater. Sometimes very useful, especially in the liver, in the spleen. You can just put it on top and do a firing, and that ball tip will cause a coagulation, which the sharp tip will actually cut through the tissue, but the ball tip will cause coagulation and it will stop bleeding. The next place where we find a lot of bleeding in is when you do an APR. Again, with the advent of neoadjuvant therapy, we have reduced the sizes of the tumor. We have so we don't get this bleeding which we used to see in the past. There was no neoadjuvant, so we used to operate huge tumors, and they will all bleed. Now that we have for GIST, imatinib, we have neoadjuvant for CA rectum. So we give this, and the tumor size shrinks. The last two GISTs, when they came to me, they were 30 centimeters in size. 1.5 years of imatinib, they came down to about 8 centimeters, and then we operated. The rectal wall was not damaged. We did a temporary colostomy, closed it once the rectal enemas were negative, and the patients were no bleeding. So the neoadjuvant actually helps you not only in sterilizing the margins, but I think it's a very great help for the surgeon because it's reduced the tumor size. You don't struggle inside that small pelvis, especially in males, and you have no problem controlling bleeding. But the most important thing that has occurred in the last 10 years, in my opinion, is the use. We did it for extra levator APRs. Now we do it for all APRs, the prone position. Because the bleeding in an APR is always from the prostate, from the posterior wall of the prostate. When that fascia gets infiltrated by the tumor, if you've gone in the wrong plane, you will get a lot of bleeding and it keep oozing. Now, if the patient is in the lithotomy position, you have to literally sit down on the floor, look up, and then try to do the hemostasis. Whereas if you have the patient in the prone position, you are looking at it from above, you are standing, you are comfortable, everybody is seeing, and you can pack with your left hand and slowly remove the pack and do a bipolar or a diathermy on the specific bleeding points. I think the prone position is the position to do APRs. You have excellent vision. You can do a wider resection if required, and you can ask your plastic surgeons to help you to reconstruct with just a gluteus maximus flaps. You don't have to go for any fancy flaps. Gluteus maximus flaps, they will do it in 1 hour, and the cover is excellent. The bleeding is easily controlled. And I think going into the prone position APR is not only useful for cancer dissection, it is also useful in controlling hemorrhage intraoperatively. These are the 2 points which I thought I should stress in rectal surgery. Other places don't bleed very much. There's nothing much to. You may have bleeding from the middle rectal vessels laterally. Nowadays, we invariably take it with the vessel sealing device, and so we don't see any significant thing. Thank you.
So, Ramesh, from the student's point of view, when you are doing the retrorectal dissection, when you are starting, how does one know that you are in the correct plane, and how do you start thinking that, no, I have gone into the wrong plane?
Yeah, so what you do is that you have to lift the rectum anteriorly and a little towards the left side. So when you're doing laparoscopic, we are operating to the right side. So you lift it towards the left side, you stretch that mesorectum, and you'll feel for the sacral promontory. You will feel the sacral promontory. On the sacral promontory, you'll feel where the iliac vessels are crossing and where the iliac vein is crossing. That will be seen. You see the ureter crossing. In thin patients, usually, or even in fat patients, if you look carefully enough, you can see the ureter peristalsis. Then what I do is about a centimeter medial to the peristalsis, I just lift the peritoneum and nick it with a diathermy, or you can nick it with a harmonic scalpel or a thunderbeat, whichever one you want. What happens is as soon as you open that space, the carbon dioxide will rush in and it will display that space. And you go in that way, it will be an avascular plane. Now, you know you're in the wrong plane if it starts to ooze and bleed badly. The moment it is not bleeding, it is avascular, you know you're in the right plane. And the veins will not be seen because they'll go behind, and the nerves will not be seen. You will see the nerve getting lifted after some time, but it will be behind a plane of fascia. So you know you're in the right plane, and if you stay in that plane, there will be no danger.
You mentioned about the prone position. Now, one problem with prone position is that your abdominal and perineal dissections are not synchronous. They have to be.
It's not synchronous. So what we do is, we do the abdominal dissection, we do the colostomy, we close the ports if you're doing laparoscopically, we close the abdomen if you're doing open. then turn the patient. But you've done a complete rectal mobilization. You've divided the rectum, you've brought out the colostomy and done it. So your rectum is completely free. And what I do is I tie and deep a nice big umbilical cotton tape on the proximal edge of the rectum. Then I turn the patient over, and then I make a horizontal incision just below the sacral tip. That's the first incision, and then go in a sort of a shield pattern. So I have a horizontal incision, two arcs that will meet in front of the anus. I deepen them, and the first thing I deepen is I keep deepening them a little bit on all sides, but then I deepen them posteriorly first, till I enter into the abdominal cavity. As you do, you will find yourself entering into the abdominal cavity because you've done the mobilization behind right up to the tip of the coccyx. So when you divide that coccyx rafting, you will find yourself into the abdomen. The moment you find yourself into the abdomen, I dissect that, and then I have small hands, so I can get into most rectums. If you don't have small hands, you can ask one of your assistants who's got small hand to put his hand into that and try to look for this thread. And then when you look for the thread, you can actually hold the rectum and slowly bring it out. Slowly. You should not do it violently, it will tear. Slowly shaking it, you bring it out, it will come out. Once it comes out, then you will see the prostate, see the bladder, and then you do the dissection carefully from the prostate in under vision and remove the whole specimen. You have to keep your diathermy or scissors in a horizontal plane. Once you keep it in a horizontal plane, the urethra will not be injured. What is likely to be injured at this stage is the urethra, and you don't want that. And you can also put your hand and you will feel the Foley's catheter. So keep doing that, feel the Foley's catheter. And so I teach my PGs to keep feeling that. I make them feel the catheter, and I stay a plane above that and divide. And the whole specimen comes out. Usually there's nothing major to bleed, but if there is, it is with a prostatic bed. Easy to do a bipolar diathermy. When you are looking down, field is wide, the light is good, brilliant vision.
Thank you, sir. Sir, do you have any experience with using Verisat, the new dispatch is available in the market for this hepatic and sacral bleeding?
Yeah, for hepatic, we have used the Tachyseed. We have used the Tacoseed. We have used that. We have not used this particular model, but the Tacoseed is very effective. You put it on top of it and hold it for 5 minutes. It just gets sealed off and there's no bleeding. Our transplant surgeons routinely use it for living donor transplants.
Do you have any experience using it in sacral bleeding?
No. See, actually, I have never had a significant sacral bleeding. My only experience was this one, and I was a senior resident. I have never had bleeding. I somehow tend to stay in the right plane, and I have not had bleeding so far.
And so, in a patient like where we have a situation, we have a very locally advanced tumor, then we have subjected the patient to neoadjuvant protocol. Now we are planning a surgery. I mean, how do you decide, especially in the frozen pelvis? How do you decide that whether we should proceed or just now abandon the procedure, especially in the presence of a lot of adhesions?
I do a very careful examination and anesthesia before I operate these patients. That is the best guide. I feel whether the tumor is mobile, whether I can mobilize it. If it is adherent to the vagina, I'm not bothered in a female, because if I remove the uterus, I can get the tumor out. And posterior dissection is not a problem. If required, you can even remove the last 3 pieces of sacrum, call the orthopedician and tell them to resect it, and you can resect it, and it heals beautifully the wound. I always excise the vagina in an API, regardless of infiltration, because it's a very thin septum, so your clearance margins will be very less. So always resect the anterior 2/3 of the vagina. I make no efforts to reconstruct it. I just leave it, and you will find after 6 months that the vagina is perfectly formed.
So, based on your clinical examination, digital record examination while the patient is under anesthesia, when would you decide based on your experience that no, this patient I should not proceed, or maybe I'll be
See, if I think that the tumor is fixed to the table and I cannot remove it unless I remove the table with the patient, I will not go into that patient. That patient, I will say, is beyond. I will send him for some more chemo or radiotherapy and say bye bye. There is a time when surgeons must learn that they cannot do every case. That there are cases where you cannot help the patient, and you should tell the patient openly and back out. Now, some of these patients will go and get operated outside, and some of them, and many of them will die because they're operated in an inappropriate way. So don't bother about that. Your reputation will be safe. Remember, there are two aspects to a patient. One is the patient's cure, but also your reputation. So reputation you don't only damage by doing an unnecessary operation, which doesn't really benefit the patient, and you are not going to do any good.
So,
So,
if you have unilateral pelvic wall fixity, would you still venture?
Yeah, unilateral pelvic wall facility, I would venture. If I think that it is only the internal iliac vessels which are involved, I will proceed. But if the external iliac vessels are involved on a good quality CT, then I would hesitate, because then you have to reconstruct the external iliac. Internal iliac you can sacrifice, but external iliac you have to reconstruct. Then I have to decide, I have to call my vascular surgeon or my CTVS surgeon who is going to reconstruct, and I tell him, is it feasible? Is it possible? If he says yes, we'll go ahead, I'll do it. If he says no, I won't do it.
Recording in progress.
And is the nerve, sciatic nerve involvement unilateral, of course? Are you
No,
still following
won't
the
operate,
same
no.
old treatment, this thing?
no. If it's sciatic nerve is involved, I will not operate, because it causes a lot of disability in the post-operative period. Then I will sit and ask the patient, I can operate, but you may have a permanent limp which may not go. You may have to use prosthesis to keep your legs straight and to walk. Your walk will never be natural. Do you want to undergo the surgery? And I can tell you that 100% of the patients whom I've told this, they've opted out of surgery, because they say enough.
Ramesh, for the prone position, your abdominal dissection has to be complete. Otherwise, you
Yes.
will have problem. So,
Yes.
what you need to tell the students that posterior is fine, you go as far as you can. But what is your anterior limit?
So
Seminal
anteriorly, I go below the Denon-Villers fascia, up to the apex of the prostate.
So seminal vesicles are exposed. At the
Exposed,
lower
yes,
part
they
of
are
the
exposed.
seminal vesicles, you stop, and the remaining part, the prostate part, you will do from below.
Yeah, and I have to do laterally as far as possible. So now, when you go laterally, you will actually see the rectum straighten out, and when you finish that dissection, the rectum will become straight from the anal canal. So that you have to achieve. If you don't, then you will struggle from below.
So I've had one encounter with a presacral venous plexus bleed, and as Ramesh said in one of his slides, this is one area. All venous bleeds are blood, but this is one area: presacral, periprostatic, veins of collaterals of portal hypertension. These are all very, very kind of dangerous areas. So I've had one encounter, and we tried all possible measures, nothing worked. And then we used the board pins. But if you are planning to use board pins after, of course, sterilizing them, you have to be careful that don't use the concave ones. You have to use the flat board pin.
Flat one.
Yeah. And then in that case, I still remember I applied the board pins on pieces of gel foam. And unfortunately, this young lady had a gel foam embolism, which presented exactly like pulmonary embolism. Fortunately, she could be salvaged and she lived. So one has to be very careful, because these are large veins, as Ramesh said, and whatever material you are using, there is always a theoretical risk of embolization. So one
The
has
other
to
thing
be
you can do is you pack the gel foam or the Sergi cell or the Sergi fibrillar into the cavity, and then you drip octocyanoacrylate glue on top of that. So the glue sort of keeps it into position, it fixes it into position. Now you must tell your assistant before you drip that don't bloody use a mop to wipe it. Just stay away. Let it completely solidify for about 5 minutes. It will solidify. Leave it till then. Don't touch it, or it will just come. All the money will be wasted. Now they have this new thing called Seraphin, which has got all the active factors 7, 5, 2, everything, and you can put it. And as long as the patient's clotting factors are all right, this will cause a clot in most places.
And packing also, as Ramesh said, wherever you are packing, please look at the clock when you put the pack and do not remove it. He said 20 minutes, depending on where you are working, but definitely not before 5 minutes.
Yes.
Most of us think that it is already 5 minutes without looking at the clock, but that is only 2 minutes or 3 minutes.
No, the best thing is to leave the table and go.
Yes.
Because then you go and see a patient in the OPD, go and have a cup of tea, go and do some gossip with the nurse matron. She will have some new gossip to tell you. For 10 minutes you do, 15 minutes you do that, then you come back, most bleeding will stop.
Because it's very difficult for a surgeon to keep standing by the table.
So that's why you should leave the table.
And wait for 5 minutes. It's very, very difficult.
So you leave the table.
Yeah. Nisar,
You don't
please.
leave the table, you have a habit of putting...
I think Sadaf
I wanted to know if anybody has any experience of using bone wax in this pre-sacral.
I've used bone wax in one.
Because I remember vaguely.
Not in the bleeding from the...
No, in this lady, we used everything except muscle. We used bone wax also. So maybe the bone wax embolized, but something embolized because she had all features of a pulmonary embolism.
I have used the bone wax routinely when I used to be the only general surgeon in the hospital and we used to do amputations. So from the tibial end and fibular end, it will bleed. So you use the bone wax, it seals it off nicely. But I've never used it in the abdomen.
The problem with bone wax, which I felt in that case, was because it didn't work. Bone wax works best, as it is called, on the cut surface of bone. But on soft tissue, it doesn't hold.
It doesn't
hold. That's why it doesn't work.
Nisar, please.
I've seen one of my senior trying all measures long back, maybe it must be 25 years back. And I remembered suddenly those ball tip which sir was using frequently in his hemostasis, which we hardly see now available, is and bone wax. 2 measures I still remember particularly, and then we came out packing the patient.
Yeah, I was going to say that in this lady, I was very, very scared. That day, I was thinking that we are going to lose her on the table. And we were all prepared that finally we will pack and come out because that is the best thing to do. But fortunately, with the board pins, the bleeding was controlled.
So with packing, there is one more precaution that you take. You pack. You then take all your hands out because you're not going to sit with the pressure on it in the post-op ward. So you take your hands and take everybody out. With the packs, the patient should remain stable for 15 minutes. The blood pressure should stabilize. If it doesn't, then that means the pack is not working. If it's getting red and soaked, that means the packing is not working. You have to put more packs or then you have to option for something else. Because you must make sure that your packing has actually stopped the bleeding.
Right. Thank you, sir.